So Dr. Sharon Lahiri received her medical degree from Rush Medical College in Chicago, Illinois, completed her internal medicine residency at Boston University Medical Center, and a fellowship in endocrinology and metabolism at the University of Chicago Hospitals. Dr. Lahiri joined the Henry Ford Health Division of Endocrinology as a senior staff physician in January of 2008 and served as the Endocrinology Fellowship Program Director from November of 2012 to March of 2025. She has conducted research in the areas of thyroid disease, obesity, diabetes, and pituitary disease. And with that, she's going to do her talk on acromegaly medical management. Thank you.
Hi, thank you for having me. I'm Sharon Lahiri from Henry Ford. So as Jill mentioned, I will be talking about the personalized approach to medical management of acromegaly. I have no disclosures. So my objectives today are to first discuss the medication options available for treatment of acromegaly. Second, discuss predictors of response to somatostatin receptor ligands. So those are the most commonly used first-line agents, as many of you probably know. So I'll spend probably more time on this group of medications to discuss what determines response to these drugs and what determines resistance. Next, review the latest algorithm for personalized management of acromegaly, and then review just very briefly just some new drugs in the pipeline. You probably heard more about that from our sponsors, so that's probably a better source for that part of the information. So we'll start with the patient. This is a patient I've been seeing for many years. She's 52 years old. She presented with macroglossia, which is an enlarged tongue and deepening of the voice. And she ended up being diagnosed with acromegaly in January of 2005. Her MRI showed an 8 millimeter possible microadenoma. And unfortunately, when I had started seeing her around like 2008 or so, we did not have any preoperative IGF-1 or growth hormone levels. So our medical history, you can see, is significant for many conditions, and comorbidities are associated with growth hormone excess, like colon polyps, prediabetes, hypertension, lumbar spine osteoarthritis, depression, and she had complained about snoring at that time and was pending a sleep evaluation. So she ended up having surgery, transsphenoidal hypophysectomy, in May 2005. I think Dr. Rock actually saw her. And pathology showed fragments of a pituitary adenoma, and the immunohistochemistry showed an immunophenotype of sparsely granulated growth hormone cell adenoma. So this will become more relevant later, why I'm talking about this sparsely granulated finding. It's relevant as to determining response to treatment. So her post-surgical labs 3 months later showed IGF-1 of 500 to 600, so quite high, almost like 3 times upper limit of normal, and a random growth hormone level of 4 to 7, which is also elevated. Prolactin was normal. So going back here, you see she has had the first-line treatment, which is surgery, but unfortunately after that, she has uncontrolled disease still. So this is something we see all the time. So this is probably the most common scenario in which we need medical management. But I'm going to talk about the role of medical therapy and how there are actually different roles for medical therapy. So as I mentioned, the most common role is for persistent disease after surgery. So that's when the growth hormone and IGF-1 levels are elevated and or tumor persistence after surgery. So as in this patient. But other scenarios in which we use medical therapy would be as an adjunct to irradiation or radiosurgery. So patients may receive radiosurgery after regular surgery to try to eliminate any remnant tumor. And that takes months and even years to work. So they'll need some type of adjunct therapy in the meantime, which would be medical therapy. Other less common scenarios in which we use medical therapy would be prior to surgery. So in some cases, there is some data out there that suggests improved remission for tumors if you use treatment prior to surgery, but it's really not consistent data, and larger studies are needed to use it for this situation. There's also possibly a role of using medical therapy prior to surgery to improve some of the comorbidities, such as uncontrolled high blood pressure, sleep apnea, high output congestive heart failure, to try to make surgery safer from an anesthesia standpoint. But also more data is needed. So that's not standard of care, but something that could be considered in individual cases. And finally, medical therapy could be used as primary therapy. This is not something we typically do, but there are studies out there, especially in countries where there may not be access to an experienced pituitary neurosurgeon. We're very lucky here in the United States to have lots of pituitary surgeons available and good ones. So surgery is first line, but in other countries that might not be the case. So primary medical therapy might be something that's more available. So this would be in poor surgical candidates as well. So here, say a candidate cannot undergo surgery because of really poorly controlled comorbidities, or they just don't want to have surgery, then you might use medical therapy first. So the patients that would be okay in doing this would be those that don't have any emergent signs, like no visual compromise, they don't have horrible headaches that need emergent treatment. You could consider that if they're really not good surgical candidates. So what are our goals of treatment? Well, it's threefold. So first of all, we want to have good biochemical control, and that would mean aiming for an IGF-1 level that is normal to upper limit of normal, meaning 1.2 to 1.3 times the upper limit of normal. And the second biochemical measure would be growth hormone after doing that oral glucose tolerance test that Dr. Corey mentioned. So aiming to have a growth hormone level suppressed to less than 1, or with our better assays, less than 0.4. Now, note that growth hormone is not a good measure for control if patient is on a medication I'll discuss later, pegvisomant, which many of you may have heard of, the growth hormone receptor antagonist, because that acts on the receptor, so growth hormone levels are not reliable in that situation. The second goal is reduction in tumor size, so typically measured as change in tumor volume or maximum tumor dimension. And the final goal of treatment would be prevention and management of any disease-associated symptoms and comorbidities. So Dr. Corey mentioned many of these. So controlling any heart failure, valvular disease, hypertension, hyperlipidemia, also endocrine conditions. Many patients with acromegaly also have prediabetes or diabetes, so that has to be controlled as well. And if they've had surgery, or if they have a macroadenoma, meaning a large tumor over 1 centimeter, or even a large microadenoma, you have to check pituitary labs. We generally check them once a year to make sure they're not developing hypopituitarism, which means low pituitary hormone levels needing replacement. Also pulmonary conditions, sleep apnea, musculoskeletal. Patients are at very high risk for vertebral fractures, about 50%. Also arthritis, and then cancer screening like colonoscopy. So what are our medical options? So I listed the different options here, A through E, and looking at the first three, A through C, those are our main groups of medications used for treating acromegaly. So somatostatin receptor analogs, that's really our main first line, most commonly used set of agents for acromegaly. Then your second category is dopamine agonists. Third one is growth hormone receptor antagonists. And then I'll talk a little about radiotherapy and also combination medical therapy. So what's the mechanism of action of these different drugs, and how are they different, and why would you pick one over the other, and how do they work? So the first set of drugs in red there, somatostatin receptor ligands. You'll see there I listed 4 medications, so octreotide, lanreotide, and then the oral octreotide capsules and pasireotide. So the first 3, those are our first generation somatostatin receptor ligands. So those medications are usually our first line. They act on certain somatostatin receptors on the tumors, mainly receptor 2, and then the second generation agent, which is pasireotide, acts on many more receptors. So not only 2, but it binds strongly to 5 and 1 and 3. So because of those differences in binding, they have different efficacies and also different side effect profiles, which I'll talk about later on. The second class of drugs are the dopamine agonists, and really there are 2, but the main one we use is cabergoline. It's given just twice a week. It's actually not FDA approved for this indication, but it's something that we do use in my practice most often in combination with, say, the somatostatin receptor ligands as add-on if someone just has mildly uncontrolled disease. And the third medication is an injectables that's given daily, so a little bit more labor intensive for patients. It's called pegvisomant, and it can be first line. I'll talk about that in our algorithm, but typically it's not because of the expense and also because it's an injection daily, but it does work very well. Okay, so first I'll talk about somatostatin receptor ligands. Sorry, this is a little bit technical, but just to help you understand the differences between the drugs and why your doctor might pick one over the other. So you'll see here in black the medications I mentioned, octreotide and lanreotide. Those are our first generation somatostatin receptor ligands. And the main takeaway from this is know that those drugs bind to somatostatin receptor 2, so SSTR2. So that's really how they act. And if your tumor expresses a lot of this somatostatin receptor 2, it means, okay, these drugs probably will work very well. And then our second generation somatostatin receptor ligand is pasireotide. And that one binds to, you'll see this big red arrow pointing to somatostatin receptor 5. So that's the main difference. It binds to 5, whereas the other two don't bind so much to 5. This one binds to 5, also binds to 2, but it also binds to 1 and 3. So it's multiple receptors that it binds to. And that's why this is a second generation agent, has maybe some greater efficacy, but because of this binding to the other receptors, there are some potential side effects, which we'll talk about later on. The main one to remember is hyperglycemia, meaning like high glucose. It can induce diabetes or it can worsen diabetes, which is like the main problem with this second generation drug, even though it is more efficacious. So just to better understand, somatotropinoma just refers to the tumor that makes growth hormone. So you'll see like what receptors are present in these tumors and why do we care? We care because you'll see that 90% of the receptors here are 2 and 5. And that's why the drugs that we have target 2 and 5 primarily. There's a little bit of binding to 1 and 3 as well, but really it's like 2 and 5. So that's why those are the receptors that we look at when we're trying to figure out, okay, is this medication going to work for this patient? And this is just a table showing the different medications I already talked about, so they should be familiar to you by now. In blue are the first generation agents. You'll see there's 2 injectables, octreotide LAR and lanreotide. Those are once a month injections, so they're long acting. And then Mycapssa, which one of our sponsors talked about, was approved in 2020. And that one is the oral capsule. So that's for people who are tolerating the injectable well and say, they're just tired of doing shots, so they want to try an oral agent. This is what you can use too. It's a daily pill. So as I mentioned, it binds primarily to somatostatin receptor 2. And then our second generation agent is pasireotide, which binds to 5 as the main receptor, but also 2 and then 3 and 1. Okay, so I was talking about how there's different characteristics and how do you determine whether a drug will work for you or not? Well, your doctor can look at all these different factors to predict whether or not you'll respond well to the first generation medications like octreotide and lanreotide. So looking at age, younger patients tend to be more resistant, so less than age 40. If the tumor size is larger, tends to be more resistant also to this class of medications. And there's something on the MRI called T2 signal. So that's the radiologist will read it a certain way. So if it's called hyper intense, that's a predictor also of resistance to octreotide and lanreotide. Whereas if it's hypo-intense, it's a predictor of more sensitivity. And the granulation pattern, as you may recall, I mentioned our patient has what's called sparsely granular pattern, and that's predictive of resistance to somatostatin receptor ligands. Now, if it says densely granulated, that's good, and that it's more sensitive to this class of medications. And then I was talking about all those somatostatin receptor numbers, like 2 and 5. So if you have low expression of 2, that predicts resistance, because remember, these tumors have these different receptors. If it's not expressing much of that, your octreotide and lanreotide don't really have the receptors to bind to, so there's going to be some resistance. Ki67 is a proliferation marker, and if this is high, meaning like the tumor is very actively proliferating, that also predicts resistance. And then AIP, which is aryl hydrocarbon receptor interacting protein, this is like a familial mutation. If that's present, typically in like young patients with large tumor, more aggressive tumors, that also predicts resistance. So these are all factors that your doctor can look at to help determine and predict how well you'll respond to, say, octreotide or lanreotide, and decide whether should I pick this drug as a first line, or maybe I should pick pasireotide or pegvisomant as first line if you're showing more signs of resistance. Okay, now what about side effects? So this is really important. Our patients have a lot of side effects, unfortunately, from these medications. The octreotide, lanreotide, I mean, all these class of somatostatin receptor ligands, they're associated with an up to 50% incidence of gastrointestinal side effects. So diarrhea, nausea, abdominal discomfort, also biliary tract abnormalities. Many of my patients have ended up having cholecystectomies because of the biliary tract abnormalities, unfortunately, and that's just part of like the side effect profile of these drugs. So that's what the first generation drugs and also pasireotide, the second generation drug. Pasireotide, as I mentioned, has another side effect and adverse effect you have to really be aware of when you try using this medication, and that is induction of diabetes or worsening of prediabetes and diabetes. So you can see here, if a patient is already diabetic, 70% of patients will have worsening of their disease. If they have prediabetes, 50 to 70% of these patients will have worsening of their disease. If you don't have diabetes at all, you're totally like normal glucose control, there's like about a 46% chance of getting diabetes or prediabetes. So it's a really, really high chance of developing problems from the glucose and needs to be monitored very carefully. The reason for this is that pasireotide, as I mentioned, it binds to that somatostatin receptor 5. So somatostatin receptor 5 is responsible for GLP production. You guys have probably heard of GLPs like your Ozempics and all those drugs, right? They act on the GLP receptor. So basically by binding to somatostatin receptor 5, you're actually suppressing production of GLP. So that's why patients tend to get diabetes for that reason. And that's why also the GLP drugs will work well if they do have worsening of disease and they need to be on this drug. Okay, so this is an algorithm actually for how to manage high glucose levels or diabetes if it does develop in someone who is taking pasireotide. So this is busy. I'm going to simplify it to 2 boxes. So basically, if a patient is on pasireotide, they should be checking their blood sugars, fasting, and after a meal. So depending on the condition, like if they have prediabetes or diabetes, probably check it daily just to see what's happening and get a closer check. If they don't have diabetes, maybe monitor like 3 times a week. And then A1C should be done initially and also at 3 months to see what's happening. If indeed someone does develop diabetes and they're requiring medications, we typically start with metformin unless there's contraindications, and then this algorithm recommends potentially adding a DPP-4 inhibitor. That would be something like Januvia, Tradjenta, those drugs, that could be helped out to help the glucose control. If there's still no improvement, then GLP receptor agonists. Now, you don't really have to follow this algorithm exactly. We can actually just follow our regular diabetic treatment algorithms in terms of managing the patients, but just knowing that GLPs work very well in these situations for the reasons I mentioned with that somatostatin receptor 5 having the causing the issue with the low GLP. Okay, so moving to our second class of medications, it's really just the one, dopamine agonists. So this drug binds to the D2 receptor on the growth hormone adenoma tumor. It's called Acromegaly. It's used off-label, as I mentioned, not FDA approved for this reason. The dosage tends to be quite high, though, between 1.5 to 3.5 milligrams per week. So this drug is typically used in prolactinomas, so it's FDA approved for that condition. And but it can be used in these growth hormone secreting tumors as well because there are receptors on those lesions. The efficacy is not so great. I mean, it's around like 18 to 30% biochemical control versus like up to 50% with the somatostatin receptor ligands. And there's only 33% chance of tumor shrinkage. Better predictors of response are mild disease. So the IGF-1 is only like 2.5 times upper limit of normal, mild signs and symptoms. If there's staining for prolactin or D2 receptor expression, those are signs that you may respond better to this medication. Be aware of some side effects. They're mainly gastrointestinal. Some people have nausea. Orthostasis is common. That just means like feeling dizzy, lightheaded, like your blood pressure can go lower and you feel dizzy, lightheaded for that reason. So we recommend taking it at bedtime, twice a week. And then less commonly, but something to watch out for, are cardiac valvular issues if they're taking over 2 milligrams a week. So I'll usually get like an echocardiogram if they've been on this drug for a while, like maybe after 6 months to a year, I'll order an echo. Okay. So the third class of medications are the growth hormone receptor antagonists. It's really just one, pegvisomant. This was FDA approved in 2003. So as I mentioned, it acts at the growth hormone receptor. So it binds very tightly to site 1 on the receptor, and then it binds less tightly to site 2. So that prevents what's called heterodimerization, meaning the receptor kind of coming together, binding to, and then causing what's called signal transduction, meaning the action of the hormone on the receptor. So it blocks that whole pathway. Because it acts on the growth hormone receptor, you can't use growth hormone levels to monitor the condition when you're on this drug, but that's okay. We use IGF-1. But this drug is very efficacious. Up to 75% have biochemical control. It also helps with any hyperglycemia. If a patient has diabetes, it helps with the diabetes control too. And Tumor shrinkage, as I mentioned, because it does act on the growth hormone receptor, growth hormone levels will be elevated. There is a potential risk of having increase in size of the lesion. So if someone has a macroadenoma, meaning like a large tumor over a centimeter, this drug will work to achieve biochemical control, but you have to really watch tumor growth carefully. And you may want to use the medication in conjunction with a somatostatin receptor ligand, which will shrink the tumor. Things that are having to be watched with this medication are elevated liver enzymes in 3%, the tumor growth, as I mentioned. They technically should have a yearly MRI if they can tolerate that and they're okay with it. It's a daily injection, but I'll talk about later on when we use it in combination with the somatostatin receptor ligands. You don't necessarily have to give it daily. I have some patients where I have them on, say, octreotide or lanreotide, and then I just give the pegvisomant maybe like once or twice a week, and they achieve good control with that. So that's one way to use them in combination and lessen the burden of the medications. Okay, so combination therapy, as I mentioned, probably the most common combination would be the octreotide or lanreotide plus pegvisomant in a low dose, like I mentioned. So the pegvisomant helps to achieve better biochemical control. The somatostatin receptor ligand, meaning octreotide or lanreotide, helps to like control tumor volume. Also, the somatostatin receptor ligand will help with symptomatically with headaches too. So this is a commonly used combination. Pasireotide and pegvisomant is another combination that could be used, less common, but you can use that as well. And then pegvisomant cabergoline, that's really unusual because cabergoline is a really weak drug. Pegvisomant is a very potent drug, so it's almost like sort of not necessary to add the cabergoline to it. And then we also do add cabergoline to octreotide or lanreotide finally. If it's like a mild case, like you're on the octreotide, lanreotide, and pretty well controlled, but not quite there yet, then you can add cabergoline like twice a week because it's not so much of a burden rather than injections. Okay, so back to our case. So just to remind you, 52-year-old woman, she had surgery in 2005 for 8mm microadenoma. The pathology showed a sparsely granulated adenoma. So her levels were really high after surgery. They were 500 to 600. Growth hormone levels were quite high too. So we started octreotide, titrated her up to 30 milligrams every month. And then we also added cabergoline. She had minimal improvement, and unfortunately, she developed acute cholecystitis. That's like a gallbladder infection, and she had to have her gallbladder taken out. So that was in 2010. MRI was done at that time for follow-up and showed a 4 to 5 millimeter hypointense lesion. So what are our choices now? Well, we could do surgery, radiosurgery, add pegvisomant, do a combination therapy, or pasireotide, but unfortunately this is 2010, so pasireotide wasn't even approved yet. It wasn't approved until 2014. So really A through D are our choices. And just of note, you know, she was very claustrophobic. She doesn't like to do MRIs. So if you see later on, like, why didn't this lady have more MRIs? It's because she just has a hard time getting the machine. So we ended up starting her on pegvisomant. She preferred just to like stop the other two and change directly to pegvisomant, just to minimize the number of medications she had to take. And she did not want surgery again. So we started the pegvisomant, and her IGF-1 did improve greatly to like the 300. So that was good. Got her to repeat an MRI. That was in 2015, and it showed up to a 6.4 millimeter focus in the left side. So it was increased in size from 2010. So that's a little bit concerning. It's still not big, but still a bit of a concern if we're going to use this medication long term. So what are our treatment options now? So we talked with her about this and, you know, said it increased a little bit. And she also was really having a hard time doing the injections daily. She just didn't like doing them. And also the drug is very expensive. So she was asking me if there was like a lower cost option. So surgery, radiosurgery, or change of pasireotide or combination. And we decided to try pasireotide. It was FDA approved at that time, 2014. We started her on 40 milligrams once a month. She had an A1C of 6.1, just so you know, at baseline, she already has prediabetes. And unfortunately, it jumped to 8% with a glucose of 227. This was after only one injection. So she said, no way, you know, let's stop it. So we stopped pasireotide. So our treatment options are sort of dwindling a little bit. So surgery, radiosurgery, or combination therapy, maybe pegvisomant with a somatostatin receptor ligand. So We restarted the octreotide long-acting. She had her gallbladder out, just to remind you too, with these somatostatin receptor ligands, so it's okay now. And we added it to the pegvisomant 10 milligrams daily. Her A1C went back to 6.1. Unfortunately, she was still having a hard time taking the pegvisomant all the time. IGF-1 was around 450. Then we talked about radiation, and she said, okay, she still didn't want surgery, referred her to radiation oncology. She had that done in 2017. And then we had to start her back on medications in interim, so adjuvant medications I mentioned while the radiotherapy works because it can take months to years. So we started her first in just octreotide LAR once a month. She wanted to try one at a time because of the cost. Her levels were still high in the 500s. Then she said, okay, she'll change only to the injections for the pegvisomant once daily. And she had better insurance, could afford it. We started, her IGF-1 levels dropped to 200s by 2018. She continued on the 10 milligrams daily of pegvisomant, doing really, really well. Her IGF-1 was actually 166 by August of 2020, A1C 5.7, that's a diabetes control, so she's very well controlled. We decided to do a trial off of it, thinking like, well, maybe radiotherapy took care of it. Tried her off of it. The IGF-1 bumped up to 276, still not terrible. So she restarted it, and we're actually talking about potentially decreasing the pegvisomant even to like, say, 3 times a week. So that's her status right now. The MRI shows a less than 1 millimeter focus in the pituitary, so it got much smaller actually with the radiosurgery. So this is the most recent algorithm from Endocrine Practice 2022. Maria Flasseriou wrote this article. And to go through it, basically you'll see at the top, tumor is diagnosed and acromegaly is diagnosed. Surgery is first line. Then if there's still residual disease, then you talk about medical therapy. So you'll see the different factors on the left there predicting good response, so densely granulated tumor, somatostatin receptor 2 positive, low proliferation index, MRI T2 is hypointense. So that would tell you, okay, this patient will have a really good response. Let's pick octreotide or lanreotide as our first medication. Now, on the right-hand side, you'll see that little bubble over there. If we have predictors of resistance, sparsely granulated tumor, somatostatin receptor 2 negative, T2 hyperintensity MRI, young patient, they have a mutation showing some familial disease, then you may want to pick pegvisomant or pasireotide. And to determine which one to pick, you might pick pegvisomant if they have, like, say, a small tumor, so you're not really worried about tumor growth. Say they have some pre-existing prediabetes or diabetes. It could help that as well, so that would be a good drug in that case. Now, if they have large tumor, say they don't have diabetes or it's really well controlled, they have high somatostatin receptor 5 positivity, pasireotide might be a good option. So you choose your first agent, then you follow them, see how they're controlled. If it's not working well, and then your next options are to switch to an alternative monotherapy. You could try combination therapy, or you could do radiosurgery. So then you do that, and you can see the different combinations down there. But that's basically the algorithm and how to choose which medications. So just briefly on the new therapies, the oral octreotide, Mycapssa, as our sponsor talked about. These are the oral capsules in the most recent drug FDA approved in June 2020. It's not for the treatment naive, it's really for patients who are already on injections, tolerating it well. Paltusotine is the somatostatin receptor 2 selective agonist. It's a non-peptide agent. It's a pill, and phase 3 Pathfinder trials showed positive results. So that's with the FDA now. And then CAM 2029, which our sponsor also talked about, is another drug. Phase 3 showed positive results. And then also these antisense oligonucleotides that bind to the growth hormone receptor and block synthesis of growth hormone receptor. They would be injections as well, and these are in phase 2 trials. So in conclusion, hopefully you better understand the role of medical management, how to choose medications, and know that we treat to attain normal biochemical parameters, smaller tumor size, improvement in comorbid conditions, and then just be aware of predictors for poor response to first generation somatostatin receptor ligands, so you know maybe better which drug to choose first or how to change medications. Be aware of the adverse effects to the different classes of medications, and then just understand the personalized approach based on the patient and also tumor characteristics. Thank you. Any questions?